You are asked to comment on some arterial blood gas result. You understand the sample was taken from a 64-year-old patient attending one of the outpatient clinic. The clinical information says female smoker with the shortness of breath, wheeze on auscultation of the chest, pH of 7.38, it is normal, PCO2 of 6.5 on the higher side, PO2 of 8 kPa, low, and bicarbonate of 38. Compensatory,
Chronic COPD.
compensation.
Type 2 failure. Hypoxia, hypercapnia. Compensate.
There is no acidosis. How can you say acidosis?
No, not
It's
acidosis.
compensation.
Type 2 failure.
CO2 high and 38. This picture is consistent with chronic COPD as exhibited by the CO2 retention in the presence of pH within the normal range. What has occurred over the time is renal compensation with the conservation of bicarbonate leading to the elevated bicarbonate level 38 micromole, which is seen here. Which of the following is the most appropriate antibiotic choice? Blood culture Pseudomonas, colistin, gentamicin, meropenem,
Maybe
tyrosine.
meropenem. Let's see. Maybe meropenem. Let's see.
Okay, let's see. Tazocine. The choice here is between the oral quinolones and IV therapy of for the Pseudomonas. Given that this patient is still spiking fevers and has an elevated urea, IV therapy with the tazocine is the most appropriate. Meropenem, carbapenem are the option for the treatment of Pseudomonas, although inducible resistance is a concern. For this reason, tazocine is the preferred option. What is the significance of that elevated urea here? I didn't get it.
Not urea high is this is for a cap. This carb 65. Not carb 65 is for a community acquired pneumonia.
Okay. Okay, if there is no renal impairment, then answer will be meropenem.
Meropenem also need patient dose reduction in CKD. Tazocine you can use in violin. Tazocine meropenem both need meropenem need dose reduction.
What would be the most practical investigation to establish the diagnosis? Thyroid function, overnight home sleep oximetry, formal respiratory function test, CT thorax, Epworth sleepiness score. I think that's one. 56-year-old man is referred to the endocrine clinic with an 18-month history of the constant tiredness. He works as a taxi driver and on one occasion fell asleep at the wheel. He finds it difficult to concentrate during the day and has a frequent morning headaches. His wife stated that he is restless and snores loudly at night and occasionally has choking episodes. He has also had very poor libido recently. He is a smoker of 30 cigarettes per day and drinking 4 pints of the large dessert every night. His only medication is an inhaler for the bronchitis, and he has had the chronic cough with sputum over the last few years. On examination, he was a large man with the coarse features and was clinically obese with the body mass index of 35. His heart sounds were normal. There was some scattered wheezing in the chest, and he had early pitting ankle edema. What would be the most practical investigation to establishing this diagnosis? Answer?
B.
Overnight home sleep.
What?
E.
E. But E is not for diagnostic.
What would be the most practical investigation to establish the diagnosis? Most practical investigation.
Most particular is the sleep study. Okay.
Yes.
E is
after
there,
B.
but is E after. E is not diagnostic. It will be here, right?
Maybe for monitoring or for questionnaire.
Okay. The diagnosis is obstructive sleep apnea, which affects the 1 to 2% of population and is most commonly found in the obese male, a smoker with the background of the chronic obstructive pulmonary disease (COPD), where causes include the acromegaly, Cushing's disease, nasal deformities, and tonsillar enlargement. Apnea occurs when the walls of the pharynx collapse during the sleep, which leads to the hypoxia and increasingly strenuous respiratory effort until the resistance is overcome. Apnea can occur hundreds of times per night, resulting in the reduction of the REM sleep. The diagnosis can usually be made by a good history from the sleeping partner, supported by the non-invasive oximetry performed at home. Full polysomnography studies are rarely required for the diagnosis but can be useful for CPAP, which keeps the walls of the pharynx open as the mainstay of the treatment and can lead to a dramatic improvement in the symptoms. Option E, the Epworth sleepiness score is merely a pointer to daytime sleepiness associated with OSA. It doesn't confirm it with test. What is the most likely diagnosis? Chest X-ray, patchy infiltrate throughout the both lung field and affecting the. Okay, Epworth is worthless, and particularly affecting the upper lobe. Okay, GGT is 30. 21-year-old man present with the 3-month history of progressive wheeze and dyspnea over the last few weeks. He has Over the last few weeks, he has been coughing up thick, rubbery plugs of mucus. There is no hemoptysis. He has a background of mild asthma, which was well controlled until a few months ago, and eczema. He had recurrent chest infections, recently requiring several courses of antibiotics from his GP, and attributes this to the damp autumn weather. And he also has a feeling of general malaise. He had been more acutely short of breath for the last few days. On examination, he was dyspneic at rest, but not the cynosed. His temperature was 37.8 and pulse of 100, blood pressure of 132 by 86, 94% saturation on air, respiratory rate of 22. His heart sound were normal. On auscultation of his chest, he had widespread expiratory wheeze with some coarse crepitation in the mid zone and reduced air intake in the right lower zone. Abdominal and the neurological examination were unremarkable. Investigation: hemoglobin 15, WBC of 13.1, neutrophils of 8.5, lymphocyte 2.2, monocyte of 0.2, eosinophil count high, and other things are normal. And chest X-ray patchy infiltrates throughout the both lung field, particularly affecting the both upper lobes. What is the most likely diagnosis?
Can you go back again?
Mm-hmm.
And the question again back. On Why not? Yes. But patient is lower lobe fibrosis. No, upper lobe. Okay. No, patient is lower lobe fibrosis.
No, chest X-ray showing upper lobe.
Infiltrated. Back.
There is a eosinophilia also. Okay.
Back. They reduce
Like
air intake in the right.
he has a background of the mild asthma, which was well controlled until a few months ago, and eczema also. Okay. And had a recurrent chest infection recently requiring several courses of antibiotic from the GP. And he attributes this is to the damp autumn.
Okay, BPA go.
If you are thinking other option, then what? Like cystic fibrosis or what?
No, not.
Then?
The
And
What
like
about-
invasive pulmonary aspergillosis, no.
No.
And
What
the
is
cryptogenic, pardon?
cryptogenic?
Cryptogenic eosinophilic pneumonia. Cryptogenic either if there is no other underlying cause. The patient is having asthma. We can't say it is cryptogenic. Yeah, and in pneumonia there will be the diffuse pattern. ABPA is due to the endobronchial colonization by the fungus Aspergillus fumigatus. It was option D. No, it's not Charles Fox. ABPA is due to the endobronchial colonization by the fungus Aspergillus fumigatus. It tends to prevent in the early adult life against a background of the worsening asthma. There is an initially bronchospasm which can progress to the proximal bronchiectasis and occasionally upper zone lung fibrosis similar to TB. And exacerbation are more common in the autumn and winter months. Patients often get recurrent episodes of eosinophilic pneumonia, and treating infiltrate can often be seen on the chest X-ray. Because plugging can sometimes causes the lobar collapse, the diagnosis is made by the skin prick testing, which causes an immediate hypersensitivity reaction. Serum precipitants are present in the 90% of the cases, and there is a high peripheral eosinophil count. Treatment is with oral prednisolone, which is usually result in the rapid clinical and the radiological improvement. Sometimes maintenance steroids are needed to prevent the relapse. A number of the studies have suggest a possible role of itraconazole therapy. Example, option C. This is characterized by accumulation of eosinophils in the interstitium and the alveolar spaces without provocation, strongly associated with asthma and atopy. There is a gradual onset in the fourth or the fifth decades of the life. There is commonly dyspnea, productive cough, and the fever and wheeze and crepitation. For this diagnosis, the eosinophil count would be much higher. Okay, similar findings, but in the fourth or fifth decade with much higher eosinophil count. Yeah, close DD actually. Let's see. Which of the following is the most appropriate next step with respect to antibiotic therapy? Pseudomonas in the MCS. Mhm. 19-year-old woman with cystic fibrosis. Okay. And there is a finding of Pseudomonas for the past 2 years and is now treated with nebulized tobramycin. On examination, C is pyrexial 37.8 and there are bilateral coarse crackles affecting the both base, more marked on the right than the left, and V's throughout. Okay, and WBC is raised. Calcium is 2.2. CRP is very much raised.
But anti-pseudomonal, CYP also has some anti-pseudomonal coverage. No, patient taking tobramycin. Patient taking tobramycin in nebulization.
What about linezolid?
Linezolid at
MRSA. Okay. Guidelines from the Cystic Fibrosis Trust recommend a prolonged course of oral azithromycin for the patient chronically colonized with Pseudomonas. Two studies, one over 3 months and the other over the 6 months, showed a positive impact on FEV1 exacerbation, body weight, and the quality of life. Okay. Which of the following is the most likely diagnosis? A 42-year-old homeless man is admitted with confusion, fever, and shortness of breath.